Welcome to our program, Ask the Experts, Understanding HRS-AKI, Practical Tools and Support for Patients and Caregivers. My name is Morgan Harrington, and I'm the National Manager of Programs here at American Liver Foundation. ALF's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. As part of our commitment to the liver community, ALF offers a range of educational programs and resources for patients, caregivers, and providers. You can find more information at liverfoundation.org. Before we begin, I'd like to take a moment to thank our sponsor today, Mallinckrodt. Their generous support has been instrumental in helping us raise awareness of HRS-AKI among the general population. We also appreciate their partnership in the development of our Caregiver Toolkit and in making this webinar possible. Thank you, Mallinckrodt, for your continued commitment to education and support in this important area. Our newest resource is the American Liver Foundation Patient Registry, the first ever patient registry for all liver diseases. Our goal is to help researchers better understand liver disease and learn how these diseases and current treatments impact patient lives. The registry is open to individuals 18 and older that reside within the United States with any type of liver disease at any stage, including transplant recipients. Participation is easy and includes a user-friendly online survey that will only take 15 to 30 minutes of your time. Use the QR code on the screen or the link to learn more to participate in the registry. Don't wait. Share your experience to help change the future of liver disease. Our featured speakers today are Dr. Kavish Patidar. Dr. Patidar is a hepatologist and transplant hepatologist at Houston Methodist Hospital, where he also serves as an Associate Director of Clinical Research for Academic Hepatology, Board Certified in Internal Medicine, Gastroenterology, and Transplant Hepatology. His clinical and research focus includes Hepatorenal Syndrome, acute kidney injury, alcohol-associated hepatitis, and critical care in acute or chronic liver failure. His work has been published in leading journals, including the Lancet Gastroenterology and Hepatology, the Journal of Hepatology, and the American Journal of Gastroenterology. We are also joined by HoChong Gilles. HoChong earned her dual BS in biology and nursing, MSN, and adult family nurse practitioner certifications from Virginia Commonwealth University and completed her doctorate in nursing practice from the University of Virginia. She serves as the program director for Gastroenterology and Hepatology Division and Liver Transplant Programs, and the Deputy Director of GI Research at Central Virginia VA Healthcare System. Her research interests include MASLD, care models, portal hypertension, and HCC. I'm going to go ahead and turn it over to you now.
Well, thank you, Morgan, for that introduction. Again, Kavish Patidar, I'm a transplant hepatologist and hepatologist. And, you know, this is a topic that's quite near and dear to me. And so hopefully I'll be able to explain some of the things we look at from a medical standpoint. I think we first need to start with what is hepatorenal syndrome, acute kidney injury. For short, we call this HRS-AKI. And HRS-AKI is a serious medical condition that can impact, particularly affect patients with advanced liver disease or cirrhosis. And here, hepato means liver, so you need advanced liver disease, and renal means kidneys. So there's a connection between the two organs, and if one, and because the liver is sick, that impacts the kidneys in this situation. And this is due to changes in blood flow that's not going to the kidneys appropriately, leading to kidney damage. And so who gets hepatorenal syndrome, acute kidney injury? And it's usually, again, as I spoke about before, it's usually in patients with severe liver disease or cirrhosis. And cirrhosis essentially is scarring of the liver. And it's not just cirrhosis, but you also need fluid buildup in the belly called ascites. And oftentimes we see HRS-AKI in hospitalized patients who have worsening liver disease. And with ascites or fluid in the belly. And the main questions we always get asked is what other symptoms we may see with HRS-AKI. And unfortunately, we don't see a classic symptomology it's a combination of few things here and there. So I'm going to go through some of the things that I want you to be mindful of in terms of tracking your symptoms. And these symptoms can range from days to weeks. But in general, most patients will report having a decreased or very little urine output. This means that the kidneys are not seeing enough blood flow, and as a result, they're reacting, they're clamping down, leading to decreased urine output. As a result of this, the water has to go somewhere and start spilling into the belly, building up in the rest of the body, particularly the legs, and sometimes it gets pretty severe. We can build up on the tissues around all your tissues in your legs, arms, belly, and so they can really impact you that way. One of the things that it could do as well is because the kidneys also clear up some toxins. Sometimes these toxins can build up to a dangerous level and impact how you're thinking. This, in combination with another complication related to cirrhosis, is hepatic encephalopathy, and so these two go hand in hand. And when you have kidney failure, you can get hepatic encephalopathy. As mentioned, because these toxins are building up, you can get nauseous, you can start vomiting, you feel very run down, out of the norm, fatigue, weakness. And, particularly the last three symptoms I talked about, they can be caused both by the kidney as well as the underlying liver disease. And as I mentioned before, how HRS-AKI happens is, in general, the liver, is a big warehouse. It detoxifies many things from blood, and it tries to keep through multiple biological mechanisms, is able to keep your body in fluid balance. When the liver is damaged, it can't perform these functions properly, and so as a result of cirrhosis and scarring the liver, you have reduced blood flow to the kidneys. As a result of this, your kidneys are seeing less oxygen and the nutrients it needs. And then it responds to this and it starts releasing chemical messengers or hormones, which can make the blood vessels within the kidneys clamp up and when it does this, it's trying to get more blood flow. This, unfortunately, it's a double-edged sword where you're clamping down. It'll also lead to kidney injury, meaning the kidneys will stop working suddenly, and it's unable to remove those wastes and toxins that the kidneys are normally supposed to do. Now, what do you need to know, and what do your caregivers need to know? Overall, I think the biggest thing as a patient is to just recognize the symptoms. Again, they're quite subtle. It's hard to tease out which one's kidney, which one's liver. But once you start noticing significant decrease in your urine output, worsening swelling of your belly, worsening swelling of your legs, and you're just feeling nauseous all the time, can't eat, something that's out of the norm, let your doctors know right away, because early detection is crucial. And we need, the faster we know, the better we can work this up and try to get ahead of the curve. Don't wait, till it gets super bad and then you have to go, be hospitalized immediately, go to the, be in the intensive care unit in those types of situations. And then it's also important that if the worst case comes to be where you have to be hospitalized, you have to get treatment for your kidney injury, you have to understand what are the goals of therapy. So it's important to ask your doctors, how can I improve my kidney function, and how can we manage the overall process? And they hopefully the plan is to provide these details to you. And it was essentially when anybody with Hepatorenal Syndrome is to treat the kidney function, try to treat the underlying liver disease if there's something that precipitated worsening liver function, and knowing that sometimes the medical therapies may not work and dialysis or liver transplant evaluation may be in the near future. Overall, when you're in the hospital in this situation, it's important to follow the prescribed diet of fluid restrictions your doctors may give. Because, oftentimes you have lots of volume on board. You don't want to be drinking excess amount of water. You don't want to be eating things from the vending machine or something that's really salty, because the more salt we eat, the more water we're going to take. It's going to make the overall picture worse in terms of managing. Take the medicines as prescribed. And then if you're, doing this, trying to manage this as an outpatient, make sure you go to all your appointments, get your labs checked, avoid any harmful substances to the liver and the kidney, such as alcohol and ibuprofen use or NSAIDs. And then for a caregiver, it's important to ask questions because oftentimes your loved ones may be encephalopathic or may be having a short-term memory loss because of what's going on with their liver and kidneys. And so it's important to ask questions, take notes, particularly how to manage care at home, talk with your nurses, talk with your doctors, and everybody around in the hospital on how to ensure there's a good transition when the time does come leaving the hospital, how to take care of your loved one at home. Next, what I want to touch on, I'm not going to go through each point, but, how is HRS diagnosed from a medical standpoint as doctors, and how is it treatable? In general, hepatorenal syndrome, acute kidney injury, is a syndrome. It's a clinical syndrome. There's no perfect test for it. There's a combination of different things where your doctor will ask you questions about your liver disease and what maybe your history in the past 3 months in terms of medications you're taking. You'll get some blood testing done. You get some urine testing done. A picture of your liver or your belly will be taken, and or your kidneys. And it's important for hepatorenal syndrome that other causes that lead to kidney injury are ruled out. So oftentimes this could be ibuprofen use or something what we call nephrotoxic agents that can cause harm to your kidneys. Significant bleeding where your blood pressure gets very low due to the bleed. We call that shock. That can lead to kidney damage. So it's important for us to rule all these things out before we can arrive at the diagnosis. Once the diagnosis is made, then the therapy is threefold. The first thing we need to do is eliminate any kind of harmful things that may be adding fuel to the fire. Look through the medications in the hospital as well as an outpatient, what may have triggered this, and stop that medication. And then we start, along with this, we start medications that could improve your kidney function with hepatorenal syndrome. And I say could because there's certain restrictions we have to look at if it's safe for you to take. And oftentimes this is based on your blood work, whether or not you're requiring oxygen and how significant your liver disease and kidney disease is. And the first line therapy for hepatorenal syndrome is something called vasoconstrictors, which improves blood flow to your kidneys. An example of this is terlipressin, which is the only FDA-approved medication right now we have to treat this. And then you have off-label treatments with norepinephrine, as well as a combination of a medication, oral medication called Midodrine or and octreotide in combination with a specialized protein called albumin, which you get through IV. Again, these norepinephrine, Midodrine are off-label, and they may work, they may not work. But it's important to know that there are therapies out there and to ask whether or not you qualify to get treatment. A big thing that can lead to reduced kidney function is infection. So it's important that your doctors and you inquire about whether or not there's an infection and if it's being treated. We want to make sure your fluid balance is under control. As mentioned before, because of what's happened in the kidneys, a lot of fluid gets built up, particularly in the belly. And of course, we want to relieve the pressure to help you eat and feel better. But if we remove too much fluid, that can make your kidney stressed out. And so we have to be mindful of that and work with you in terms of how much is too much. Of course, unfortunately, our medications are not a silver bullet. There are instances, I would say, about 15 to 20% chance, up to a 15 to 20% chance that you may require dialysis, where even the medication is not working and you have to be put on a machine to clear out those toxins that your kidneys normally would do. And lastly, because the liver is leading the ship in terms of what's causing your kidney damage, the cure of this is actually liver transplantation. And so oftentimes anybody presenting with hepatorenal syndrome, we as doctors, in particular as a transplant hepatologist, we want to see if our patient is a candidate for liver transplant, and we start the evaluation for you.
When we're living with HRS-AKI, I think it's important. I always have a conversation with the patient and how liver disease not only impacts the patient, but their family. And it's important that they bring caregivers to appointments so that they can understand, their care plan, ask the appropriate questions about treatments and procedures, really and the importance of knowing the medication, but also the schedule, and having good discussions about goals of care with your healthcare team. They are instrumental, caregivers are instrumental in participating in not only monitoring, but also aware of, what daily labs mean and what their results. And it is important for the caregivers to understand and recognize any new symptoms or changes on how the patient feels, because this way it will facilitate communication with the healthcare team. We need to understand the fluid intake and output, and also if there's a change, and that should be really important to communicate with the team. But also, we are doing things to support patients by, working with physical therapy, because we need to get these patients, you need to keep moving, because, you can get muscle mass wasting, and it's important that, you're moving and preventing muscle loss. Helping patients, if they are requiring prolonged hospitalization, getting them up. We want to make sure that they, are not at risk of developing infections, especially lung infections, and using really limited pain, because it can affect mentation, and can because when you can get confused, that may be a sign that there is something going on that can precipitate or cause acute kidney injury. We're not restricting protein, so it's really important that, because oftentimes patients are sick, so we need to tell caregivers, because they're often the ones preparing meals, and to, make sure that they're compliant with low sodium diet, because that's the one thing that they can really control and understand, if a fluid restriction is required. And also because calories are important, oftentimes we get dietitians to help patients and their families to make sure that they're getting the caloric intake. And if there's any type of eating difficulties, that also needs to be communicated, because nutrition is so important in this disease. We want to prevent complications, especially avoiding getting infections. So in this era of COVID, we want to make sure that we're practicing good hand washing and hand hygiene, because there's nothing that could spread more bugs in the hands. I like to give our patients inceptus spirometers, so that way they could expand their lungs to prevent getting, pneumonia, or what they call atelectasis, and also getting them to move, because you can develop blood clots. This is a difficult time for the patient and their caregivers, and it's important that we engage, and so that we prevent social isolation, and encourage families and friends to stay connected with these patients and the caregivers. But sometimes we may, or they need additional support, like we have social workers and other interdisciplinary team members that could really help them, guide them through this disease trajectory. Next. So how can HRS-AKI be prevented? In some cases, it can't be prevented, because that's really the natural history of end-stage liver disease. But, we can help by managing, and understanding the underlying liver condition, and to avoid progression if we can reverse it. If your liver disease is caused by alcohol, we want to, encourage, cessation and avoiding alcohol and drugs that could harm or further harm the liver and kidneys. Again, emphasis on preventing. It's a lot about is prevention strategies to avoiding and preventing infections. And when it's recognized, like fever, you need to tell, the healthcare team immediately, and do not delay, in actually getting that evaluated. Staying hydrated and, complying with the low sodium diet that we discussed, and, but also making sure that we have optimal nutrition. And there are ways that we can monitor, kidney and liver function, especially with labs, but also knowing what the early signs, like if there's additional fluid buildup, if you have increased swelling, if you have, if you're bleeding, any signs, because, sometimes, they can have some confusion where the caregiver really knows what's going on more oftentimes than the patient. So, and really be cautious of procedures like paracentesis. And this is why it's important to maintain a good low sodium diet to prevent the increased need. But sometimes you can't avoid that. And they do require paracentesis because it's really uncomfortable.
I really appreciate that fantastic presentation and really broad overview of everything related to HRS-AKI. We do have one of ALF's patient advocates here, and we have Jay Beyer-Krupensky. He is going to share a little bit about his journey with HRS-AKI with us.
Thank you. Well, as you've kind of heard already, this syndrome is very, very challenging. So I was first diagnosed with liver disease at the end of 2011. And at that point in time, went and saw my primary because I hadn't been feeling well. And she recommended that I go see a hepatologist. And so I was under the hepatologist care for a number of months and was prescribed some steroids and some other treatments to really kind of help my liver along. And actually, my liver numbers started to get a little bit better. And so they were kind of optimistic that maybe this was just a little bump in the road. And that because the liver can kind of heal itself, that maybe, I would come out of this unscathed. But in May of 2012, I saw my primary and my hepatologist on the same day. And I hadn't been feeling great, but I guess I didn't really realize how poorly I actually was doing, nor did my wife or my two smaller children who were 7 and 12 at the time. And when I got home, my hepatologist and my primary called me at the same time together and said, "You will go to the hospital. They are waiting for you." And I was like, "Well, why?" And they're like, "Your kidneys have stopped functioning." And so my wife happened to be working at home that day. I kind of yelled up the stairs and said, "They want me to go to the hospital." And she's like, "What?" And neither of us, again, knew how really sick I was at that point in time. When I got to the hospital, they whisked me into a room right away, didn't even really have to check in. And that's really all I remember for the next 49 days. I was put in ICU. They ended up taking 38 liters of fluid off my abdomen, so I must have looked like I was pregnant. I knew I was overweight, but I didn't realize that it was all fluid. And during that time period, they kind of really debated what to do with me. Unfortunately, I had a lot of really good doctors, and but they debated at one point in time, I guess, I found this out after the fact, whether they should really dialyze me or not. That's how sick I was at that point in time. So on the MELD score, I was actually way over what they normally, it ends at 40, and I was a 44 at that point in time. So that's really how sick I was. But fortunately, they were able to do a lot of interventions at that point in time, and that was before the FDA-approved drug was on the market. This was back in 2012. And so fortunately, they were able to kind of patch me together, get me out of ICU. But at that point in time, my muscle mass was absolutely horrible. As you kind of heard earlier, I just kind of wasted away, during that 49 days being in ICU, but also because my liver wasn't functioning the way that it should at all. I just couldn't even rebuild any muscle mass. So it was really a struggle even to learn how to walk again, how to actually, be able to feed myself. So I ended up doing a lot of physical rehab for about a 3-month time period, and finally got out of the hospital and was able to actually be evaluated for liver transplant because I had been on dialysis long enough at that point in time where my kidneys were severely damaged. So that's one of the things that I think is great now with the early interventions that there are, is that patients don't get to the point of being as sick as I was and in need of a kidney and a liver transplant, which I received at the University of Minnesota back in January 14th of 2013. So it's been an interesting journey, one that I never thought I would be on, one that my, caregivers, my wife being my primary caregiver, really kind of struggled to even, kind of figure out what was going on with me. Fortunately, I happen to live next door to a gastroenterologist who actually trained my hepatologist. So that was kind of fortunate because he really helped guide us through the whole process. But it is really hard for the patient, for one, because as you heard before, you can be very encephalopathic. You're dealing with all these fluid restrictions. I had paracentesis, twice a week until I was transplanted. And so managing all of those things get to be really difficult for the patient, but more so for the caregiver because they're the ones that really have to look out for the patient because a lot of times we can't. We don't really realize what's going on with us if we're encephalopathic, and also need to be constantly reminded about the good things that will, or the things that we can do that will help us, at least maintain for a time period until we could be transplanted. So it definitely is a challenge, I think, for everyone. And I think, everyone in the medical profession has gotten a lot better on dealing with this syndrome primarily. In 2011, I think there were, even at being in the Twin Cities metro area and going to a major hospital, they still really kind of struggled. What do you do with this patient that exhibits in this way? So I think we've come a long way, but there's a long way to go, not only with patient education, but just research in general.
Thank you, Jay, for sharing your story. It's so powerful to hear what you've been through and then to be able to see you today, being here with us and sharing your story and your journey. And, you mentioned that there, of course, looks a little bit different for people nowadays because we do have a medication that is approved and, there is more awareness surrounding HRS-AKI, but of course not enough. As you mentioned, education is continuing to grow. And that is part of what we're hoping to bring to the general population today who maybe have never heard of this before or don't know anyone who's been impacted but are experiencing symptoms or have just been diagnosed themselves. So thank you so much for being with us today. I do want to jump into a few questions that has sort of come up as we've all been spending time together today. And one of them, I want to go back a little bit to the hepatic encephalopathy. I know that can be a really powerful symptom associated with all liver disease, but specifically within HRS-AKI. What is something that you would want caregivers, and any of you can answer these questions, I would encourage all of the conversation, but what are symptoms that people should be looking at specifically related to hepatic encephalopathy early stages, where maybe people are noticing early signs of confusion or memory loss, or maybe a little bit of agitation? And then what would be your encouragement for the caregivers to help someone maybe seek care if they're not quite feeling like they need to yet?
Kavish, do you want to go first, or?
I think, Morgan, that's a very important question. I think with hepatic encephalopathy, there are some subtle early signs. The patient themselves may not think it's anything major, but the caregivers are really the ones that are, figuring it out, like, hey, something's wrong. So it could be, memory, really a long time, being able to say a sentence to them or answering a question where a question gets asked and, it takes 30 seconds to a minute to answer it, very slow. Oftentimes they can, their sleep-wake cycle starts, changing. They're not sleeping properly. And these are all early signs of hepatic encephalopathy. And then, of course, the overt signs are when they clearly are now confused. They may recognize their caregiver, but they're just, they start to get lethargic and somnolent. And at that point, it's really important to, call EMS, take them to the hospital, or, if they're awake and alert enough, drive them to the ER because we need to, treat the encephalopathy, which, HoChong can talk about. And of course, anything, HoChong's been around treating or advanced liver disease patients for a long time. And I'm really interested to see what she thinks in terms of early signs as well.
Thank you, Dr. Patidar. So, I treat and discuss, the first time they become encephalopathic because, we want to make sure that there is not a cause why people become confused. But then when they do get established with a diagnosis of hepatic encephalopathy, which we often call HE, there is medicines that we can give, but first we want to make sure that we exclude infection or, bleeding or other things that can actually cause, that are ominous signs, right? And like Dr. Patidar said, that sometimes it could be subtle and it could be, really, personality changes. And, oftentimes I have to counsel, caregivers because I'm like, I don't know what my husband or my wife, I don't know them anymore, because they can have, significant personality changes. But, the caregivers are the ones that really can detect subtle changes much earlier than what we can. So one of the things that too, when they develop pretty profound hepatic encephalopathy, is that I teach caregivers, and we call this asterixis, or the liver flap. So if you have them hold their hands out, and they can develop this tremor, and so oftentimes my patients know, they already stick their hands out for me for for me to assessment or clinic visits, and so we kind of teach the caregivers kind of the overt signs of when that happens. But there are medicines that we can give to control hepatic encephalopathy after we make sure that this is just the trajectory of their liver disease and there's nothing ominous going on. And that is lactulose first, and that is a yucky syrup that we give patients that's very sweet and people don't like it. But what happens is, because of that ammonia buildup, we want them to have, 3 to 4 loose bowel movements every day. And also make sure that they're not taking medicines, because like Dr. Patidar said, there are sleep cycles. So, people want to take like sleep aids or, and that can also, or pain medicines that could increase, their risk of developing hepatic encephalopathy. So we want them to have, 3 to 4 bowel movements. And then if they don't respond, or they're not intolerant, or if they're intolerant to the lactulose, or, there are other contraindications, because they get too much diarrhea, or there's a medicine called rifaximin that we can give that also is known to prevent hospitalizations or readmissions for hepatic encephalopathy. But then if it's pretty persistent, we also want to make sure we look at people's anatomy to make sure that there's no, shunts that are made because of the cirrhosis, and make sure that, they're not shunting more blood away, causing, direct ammonia buildup, because a lot of blood is being diverted, away from the liver. Okay. So we want to make sure, and they're called splenorenal shunts. And those are, when people are really having an issue with hepatic encephalopathy, they're really struggling, they're in and out of the hospitals. We want to make sure that they don't have these shunts, because in some cases they can be addressed.
Excellent. And just to piggyback on that, what Dr. Gilles said is it's omnious. We want to rule out omnious signs. So it's hard to say what came first, chicken or the egg. So HE can precipitate AKI and vice versa. And so if it's important that if somebody has overt symptoms, to check their electrolytes, because if it's something out of balance, we can fix that. That can tip somebody over to get HE. If it's AKI, we want to react quickly, treat it before it progresses on and develops into HRS-AKI. So I think this is an excellent point, particularly from a caregiver standpoint, and what to look out for as an early sign.
And from my perspective, the patient and what my caregiver experienced, having gone to the hospital 12 times between my major hospitalization and when I was transplanted, which was like 7 months. So I was in and out all the time, was one, making sure those early signs is really important. And when in doubt, go in. The other thing is make sure they take their medication, because guess what? We don't want to take those two things. Lactulose is horrible, but crystallose, which is another option, is much more palatable, but we have to take it. And there were many times when I wanted to go to a a holiday function and I didn't want to have an issue because it can be severe. Those bowel movements are not necessarily nice. And the patient will not take their medication because they want to do something, but you will end up in the hospital if that happens. So, it's a balancing act, but those early signs I think are really the critical thing for the caregiver to understand, because then you will really maybe avoid that hospitalization. Excuse me. So.
Well, I appreciate that. That is such great information. And Jay, your perspective on that is so supportive. What we oftentimes hear, that it can be challenging to have patient compliance, and, hearing, your side of that is so valuable for us. Kind of along the same lines, thinking in terms of, Jay, you had mentioned that you had been hospitalized for quite some time, and alongside that, you needed a lot of additional therapies. Is palliative care something, when someone is diagnosed with HRS-AKI specifically, does palliative care oftentimes come into the conversation in order to maintain kind of where the person is at physically, emotionally, as well as support for the caregivers?
And that's something that can really freak a caregiver out and the patient as well, because they really don't understand what palliative care is. It's not hospice, and sometimes people will make that parallel. Now, it could lead into that depending on the situation, but it's not that. It's really looking at that holistic kind of approach of all those things that you need to try to maintain the person as long as you possibly can to get to the point of hopefully being transplanted if that's the option, or even just getting the person through that time period. And so it's really critical to use those resources. And sometimes I think people are resistant to that. We see that with our support group here at the University of Minnesota, where sometimes people will just say, no, I don't want to talk to them. And it's like, why not? Because they can be really instrumental in getting you to that point of being able to, maintain until transplant, if that's the ultimate goal. So, but it's hard to hear that word, because it's people associate that with the end of life, and those are tough to things to realize that may happen. But palliative care is an excellent resource.
I completely agree, but I think that healthcare providers need to approach it in a very delicate manner and really explain the differences of palliative care versus hospice. Now, I think, caregivers, it's a huge burden, especially when they've been, supporting their loved ones for a long time. And one of the nice things about palliative services, I always describe it to families and caregivers that, this is an additional support for the patient, but also for them as caregivers, right? If they're weak and prolonged. So an example is that palliative care, they're very good at getting, like, maybe you need a hospital bed that, that needs to be sent to your house, or additional nursing, home care, or, home PT, because, we want to, keep patients out of the hospital, but it often requires, it's often a catastrophic time, but also it's financial, because it could be a financial burden, because, caregivers often have to work, right? And they have to really employ, it really takes a huge village. And I think it's, your perspective on palliative care is very important, and it's spot on. But also, I think as healthcare providers, we need to approach it in a very delicate and respectful manner.
Yeah, I completely agree with what both of you guys said. It's important for us as healthcare providers to really help describe the differences. If we are able to do that carefully and appropriately from the get-go, then a patient will be more willing to accept those services. And I think there's a mental and spiritual part that palliative care gives that, unfortunately, as a doctor, I'm not the best trained when it comes to handling these types of sensitive and emotional aspects, which palliative care is really helpful for. They also help with other symptoms that may not be related to liver disease, but could be connected to liver disease. A good example is, dry, really itchy skin. If someone's on dialysis for quite some time, they get really itchy, and they can be helpful in managing that, as well as emotionally. It is a marathon sometimes, and so being in the right frame of mind and helping with anxiety and depression is going to be very important for mental health.
Yeah, thank you for covering that. I think like you both, all three of you really mentioned the difference between hospice and palliative care. I think those lines oftentimes do get very blurred for people, and it can be such a tough area to approach. And so having that delicacy and being able to really describe the benefits to palliative care and how it really can work as that bridge and that transition can be very powerful. So I am going to jump back into our slides, and we do have a few commonly asked questions and frequently asked questions that I would love to hear a little bit more about as we start to wrap up. And so, of course, the first question is, I think, what a lot of people ask when they first hear they have this new diagnosis, and that is HRS-AKI fatal?
And I'll take the first question. It definitely can be fatal. If the older literature will tell us, if you don't treat patients with HRS-AKI, we have up to a 80 to 90% risk of death within 2 weeks. And so we take it very seriously, and that's why we know that early treatment and aggressive management can improve your survival chances and give you that window, because transplant is the cure for HRS, and we want to give that window for somebody to be able to get to that point or be able to be evaluated for transplant. Because if we don't give enough time to do that, then the window can be lost. And so we need to take HRS-AKI overall very seriously, because again, it is fatal.
Yeah, it could be acute and it's, very short duration, and has a high risk of death. But reversing the AKI, and sometimes like in Jay's situation, they can develop, CKD or, chronic kidney disease. But, early diagnosis, is very key. We need to immediately rule out other forms that Dr. Patidar discussed of, other types of kidney injury that happens with cirrhosis. It's not always HRS, AKI, but we need to, promptly recognize, work that up, and manage it, because that will increase, the risk of it will increase and improve survival. And liver transplantation does offer the best curative option. And in some cases, they may require both liver and simultaneous kidney transplantation.
So what about recovery? What does that really look like? Can the kidneys recover? Or if it does become, CKD, if it does become chronic kidney disease, or is that only really saved for kind of the acute phase?
So I think Dr. Gilles touched on this here recently. And if you start treatment early, the kidneys can respond to treatment and they can improve, and they can recover. If we wait too long, then we may have missed the window of opportunity to really reverse their kidney function. And oftentimes the kidneys will continue to deteriorate and function, and then that will lead to requiring dialysis, like what happened with Jay. And if somebody were to respond to treatment before transplant, guess what? Studies have shown after transplant, you're less likely to develop kidney disease after transplant, less likely to require dialysis after transplant, which is huge. You heard Jay's story. Being on dialysis is not fun, and we really wanted to try to avoid dialysis as much as possible. And so, chances that the kidneys can recover, it all goes down to asking the right questions as a patient. The providers, trying to act quickly and start therapy as soon as they are able to.
So just wrapping up, as we look towards what recovery is there anything specific that we can do? I know we've talked a little bit about this in terms of diet and including, multidisciplinary care, but what are things that you can do to help aid in recovery from HRS-AKI?
So I think, we discussed, early recognition and getting evaluated. right? And I think that Jay was very fortunate to have multiple specialists, especially a next door neighbor. And sometimes we don't have, patients don't have that, opportunity or resource. It's really about early detection, early recognition. And if you don't know, like Jay said, go in and get evaluated, because that is really critical, because time is of the essence. There are many things that patients and their caregivers can do. One is adherence to medications, like sometimes when it's tough, like with lactulose, and you want to make sure that you focus on adequate nutrition. And really, I always talk about like control things that you can control. And making sure you get that bedtime snack and eating, you may have to, eat, smaller meals, because sometimes you feel full when you have, abdominal fluid buildup. And, but those calories are essential. And we touched upon this, there's a lot of fatigue, in patients with end-stage liver disease and those that have superimposed, AKI. But it's really important to prevent, an infection, because that can unfortunately turn into a downward spiral. And just get up, be active, move, even when you're tired, because it's really important to not lose as much muscle mass as possible, because that also has a bad outcome associated even after transplantation. It increases the risk of infection even after transplant. So, and then avoiding, unnecessary medications. The liver has to already work hard. You want to make sure that, you avoid medicines that could also, cause further damage to the kidney. So it's really important to have a good medication list. Oftentimes, when you're confused, you're not going to know. So I think the caregiver is having a good up-to-date medication list is so helpful, and a good communication tool with the healthcare team, because we really need to reconcile and kind of really evaluate what medications that you're on. And, and keep up with the appointments, because, compliance and adherence is very important, but also we can detect things earlier, but we don't know what we don't know if people don't show up for, their appointments. And you might have a good excuse, but it's really important to keep those appointments and engage with the healthcare team. And, I really encourage, the caregivers to really employ all the support systems that you have, right? Church, work, your friends, because it is an overwhelming task, and for the patient, but also their caregiver. And so those are kind of the tidbits, really just focusing on the things that you can control, common sense things, focusing on good nutrition and infection prevention.
And I would say too, don't be afraid to ask questions, and ask a lot of them, and do that often, but don't be afraid to ask for help, like you're saying, because it does take a lot of people to get you through this whole experience. But sometimes people are so reluctant to do that, and that's really the key. And don't be afraid to discuss it, because too, sometimes people with liver disease will have the kind of the stigma and everything else about having a liver disease, and they need to just get over that and not be afraid and talk about it, because that will help them get through it as well.
Such great words from all of you. We do have on ALF's website, and I will put it in the description for our video, a caregiver guide for people who have HRS-AKI or have loved ones who have it. And there are medication trackers, appointment trackers, symptom tracker on there, as well as all of the specialist phone number spaces. So kind of aligning with what you were talking about, just making sure you're monitoring those medications and keeping those appointments and showing up. And sometimes when you have so much else going on, it can just be helpful to have it condensed into one space. So that was something we felt very fortunate to be able to develop, and hopefully it'll provide some support as well. So as we wrap up, we just have a few conclusions we want to go through, and then just some parting words from each of you for what kind of words you would share with patients as we finish.
Well, we discussed how HRS-AKI is a very complex condition, and that links the health between your liver and kidneys. We emphasize understanding its symptoms, causes, and treatment options, and can empower you and your family member to make really good informed decisions and communicate better with your healthcare team. If you have liver disease, talk to your doctor about your risk for HRS-AKI and what steps you can take to protect your health. With new medications, the landscape of HRS-AKI management has really transformed how we care for those that have HRS-AKI.
Do you have any last minute words that you'd like to share with patients or family members or anyone who might just be learning more about HRS-AKI, or maybe a family member or themselves were recently diagnosed?
So I've been, managing end-stage liver disease for a long time in the absence of medications like terlipressin, and that have been ineffective. And so it's really promising and hopeful that, we have medications available. You want to make sure that you are linked with a good tertiary care center. And sometimes you may have to travel a little bit, to get there, to get those expert specialists to manage. But I want you and the patients and the caregivers not to give up on hope, because we do have, effective options if we can identify this condition early. And I think communication and learning about this disease is the first step in improving your health outcome.
I totally agree with what Dr. Gilles said. I think with this medication that's now approved in the U.S., which is terlipressin, which is exciting because we have an actual treatment that potentially could really help you and help the kidneys recuperate. And the only way we can improve awareness about this disease and the treatment is you asking for it. Ask, do I have HRS-AKI? Do I qualify for treatment? What are my treatment options? I think asking those simple questions, you really start empowering yourself and being part of your health, your management of your health. And so, again, as Jay mentioned before, ask questions. I think you can never go wrong asking questions and seeking help, because that's the best way in preventing a downward spiral. And if we always want to be proactive and not reactive when it comes to complications related to liver disease.
Those are all great things, for sure. And one thing I would say is I wear a bracelet that says, excuse me, get a little, that says never, never give up, because there is an upside to this and you can survive.
Well, we really appreciate all of you being here, Jay, for giving us such a heartfelt story and really being able to relate to the patient aspect of what this experience is truly like. As we continue to wrap up, if anyone is ever looking for more information after this program, we encourage you to visit liverfoundation.org. There you can also find details about our virtual and online support groups, as well as opportunities to get involved as an advocate and be similar with Jay and share your story. We also invite you to connect with us on our social media platforms, and you can find us on Facebook, Instagram, LinkedIn, X, formerly known as Twitter, as well as YouTube. We look forward to staying in touch.